Well, good afternoon. I want to thank the Biden administration, as well as the Cancer Moonshot for everything that they have done to be advocating for the cancer community and colorectal cancer for well over a decade. It's my pleasure to be here today on this panel. I'm Nilo Azad. I'm a professor of oncology at Johns Hopkins, and my clinical work is really focused on taking care of patients with colorectal cancer, especially early onset and metastatic patients. And I've run our drug development program, our phase 1 program there for many years as well. Please introduce yourself for everyone on the panel and tell us how you are connected to the mission of improving outcomes for colorectal cancer.
My name is Arif Nathu. I'm the CEO and co-founder of a technology company called Komodo Health. We focus on taking a look into patient journeys across the entire US. So we track the journeys of over 300 million patients. We see how they experience healthcare in this country, and we seek to understand what that means to them and what we can learn as policymakers, hospitals, insurers, drug developers, patient advocates to improve quality of life and healthcare outcomes.
Hi, I'm Phone Gallagher. I am the president of the Colon Club. We focus on the early age onset that's diagnosed under 45 population. I'm also the research advocacy program manager with Fight Colorectal Cancer, and I am a stage 4 15-year rectal cancer survivor.
My name is Elad Sharon. I'm a medical oncologist at the National Cancer Institute, where I actually work also on early drug development in our phase 1 clinic. But primarily what I work on is a national program of immunotherapy and other targeted therapy drug development that we run at up to 2,000 sites throughout the United States, all funded by taxpayer dollars through the NCI. And unfortunately, I feel that we obviously need to do more for colorectal cancer in general through these networks and through these efforts because clearly what we've done thus far is not enough.
My name is Kathy Ng. I'm a professor at Vanderbilt Ingram Cancer Center. I am the co-director of GI Oncology and the co-leader of the GI research program at Vanderbilt. I conduct clinical research, and on behalf of the NCI, I am the co-chair of the GI steering committee. So my primary focus is colorectal cancer, and especially early onset.
So, Dr. Ng, I'm going to start with you. There has been such progress in understanding the biology of colorectal cancer over the last 10 or 15 years. So where would you say that the science in terms of treatment of patients is most exciting right now when it comes to colorectal cancer?
That's a great question. I think the most important steps moving forward have been primarily focused on personalized medicine or precision oncology. But what is happening is precision oncology is wonderful, but we're breaking down colorectal cancer into very small subsets. And as a result, we really need patients to enroll to clinical trials. We have to screen a lot of patients. You'll see that one of the drugs that recently just got approved only impacts less than 4% of all colorectal cancer patients. So we have to screen so many patients to identify those individuals. And we have to find ways to get patients into clinical trials. I mean, to date, less than 10% of all patients enroll into clinical trials, and we need to find other methods, and I think Fong is going to talk about that moving forward, including telehealth as well as other ways to make our lives easier for our patients so they have access, and we can work with them to enroll to clinical trials.
Yeah, I think we really need to leverage technology in this space because when you look at COVID, one of the things that happened was we were able to use telehealth across state lines. And that really allows for the access for people who are in the rural communities, those who don't have the ability to travel to these NCI centers to get access to the trials. And now that those emergency provisions has ended, we've completely moved backwards. We're back to having to either travel to those centers, and we don't get reimbursed for travel, we don't get reimbursed for all the cost of time lost from work. All these factors really weigh in, especially when you're living paycheck to paycheck. So when we're talking about access and affordability, we have to make sure that everybody can get into these trials at like you said, the quality of care.
And I think it's important, and we were talking earlier, it's really important to keep in mind when you have a rare cancer, you may have a randomized phase 2 study, but for all phase 3 trials, there's a control arm. And that control arm is the standard of care. So how can we incorporate the standard of care so patients can get access to their care with their local physician? There's great local community partners out there. There's also great retail, we were talking about retail pharmacies. We work with, at Vanderbilt, we work with Walgreens on a regular basis. How can we incorporate working with these retail pharmacies and across state lines? Every single state, all of a sudden it's different. I have to go get a different license now in every single state to do telehealth. And it's extremely expensive as well for a physician.
Yeah, and I think that it is wonderful that the president is advocating for so much financial investment in cancer, but we also have things like this, which are really low-hanging fruit and doesn't cost much money, because we know we can do it, because when COVID happened, the entire medical system was able to flex to it. And in the last couple of years, that's changed completely since COVID has abated. And many professions, the legal profession has reciprocity of licensing, and that's all we need. And if that could be done by executive order or by working with different state governments, it's a very quick solution that would, in one moment, improve the quality of life and potential enrollment of patients in trials. So I'd really love to advocate for that being something that the administration takes on. So Dr. Sharon, Dr. Ng was just talking very much about how we need patients to enroll in clinical trials more. Can you talk a little bit about ways that we might be able to innovate how we do clinical trials? I mean, that's a big part of the NCI's mission, right?
Certainly. Bringing clinical trials to patients in their local communities has been something that we've done now for actually quite some time, usually through the cooperative groups, like SWOG, ECOG, Energy, and the Alliance, as well as the Children's Oncology Group. As I was mentioning before, there are up to 2,000 of those around the country and actually around the world. The FDA recently came up with something that they called Project Pragmatica, that is also intended to facilitate that type of clinical trial innovation, as it were, by taking at least some questions that we might be able to answer with a lighter footprint, less data collection, and essentially less cost, but still end up with answers that are deeply and important to patients. It doesn't necessarily mean that every trial has to be that way. We obviously want to learn more and be able to utilize everything, every part of the clinical trial, basically, to learn more for our patients going forward. But in some instances, that's actually one way that we might be able to both lower costs, increase access, and improve outcomes for patients by actually finding the right clinical trial that might be able to de-risk and decelerate some of the rapid machinery that has actually, over time, increased the cost overall for clinical trials generally. In industry, I've heard estimates of the cost of enrolling a patient is up to $100,000 and maybe more in some cases. So that's on a per patient basis. That can be very expensive. And you mentioned, of course, also the screening cost. If there is some way that the NCI could potentially, work almost as an honest broker, as it does in certain instances, NCI Match and some other trials, where there might actually be able to be joint screening with multiple different arms, that might also facilitate this new era where smaller and smaller subpopulations of larger groups can be studied on a clinical trial, a single clinical trial with a single screening procedure.
So I would love for one of the two of you to just address the word screening, because we just talked a lot about screening in a totally different context. And so we're using the same word, but I think we're using it a little differently, yeah?
We are certainly, and
okay.
I do apologize. So screening for a clinical trial as opposed to screening for colorectal cancer to begin with. Of course, we do have prevention clinical trials. Those are really important. But in this context, yes, you're right. I'm talking about taking a patient, finding their specific mutations or markers or some features of their tumor and determining whether or not they should be enrolled on a specific aspect or arm of a clinical trial.
I do want to mention one thing, just tying into what you just stated. The reality is, so I work on behalf of the NCTN, or National Clinical Trials Network, for the NCI, which is on behalf of the 4 cooperative groups. To date, It's been over 21 years now I've been in practice, and the reimbursement rate for NCI-sponsored studies, especially for participation in these national NCTN studies, is extremely low. And you just stated it's quite expensive based upon pharma numbers. The reality is because the compensation reimbursement is rather low, it hinders the interest from academic centers and other centers in participating in clinical trials. And as a result, it takes much longer to complete a clinical trial. And as a result, pharmaceutical companies also are a little bit dissuaded from participating specifically in NCI-sponsored studies. But yet we want these NCI-sponsored studies because these are the trials that pharmaceutical companies do not necessarily want to run. Whether it's about repurposing drugs or whether it's about thinking about a symptom management and using novel approaches in that way. So we really would love to partner, obviously, with the NCI. We love the NCI. Let's be honest. It's just, they're also hindered by the fact that they have limited funding, but it really impacts our capabilities to complete clinical trials appropriately and to get people vested.
Yeah, I think it really results in a lot of clinical trials being around expensive new drugs rather than solutions that are broader but don't end up being as financially viable for companies. Can you talk a little bit about what patients need to be able to participate in clinical trials? Kathy mentions only 10%. What is happening and what could we do to help people participate in studies more?
We've talked about education and awareness today, and I think clinical trials is a huge, huge opportunity to talk about that. A lot of people think, oh, clinical trial, that's the last thing you try before, it's the last resort, and it really isn't. It should not be. And there's a lack of knowledge in what it takes to enroll in a clinical trial. Just because you want to go there doesn't mean that there's a spot open or that you can get there or that you qualify through screening. So, it's really important to know things like your biomarkers and to have conversations with your oncologist on what's available to you. But unfortunately, a lot of times there are oncologists that go, well, I don't know of any clinical trials for you, and it ends there because the patients go onto the clinical trials website and it is a monster to try to navigate. We don't speak med speak. And so to try to navigate that, to try to find the things that even fit you, it takes a lot of tenacity just to get through that. So if we can educate our patients on what it takes to get on it and why it's to their benefit to give it a try, I think that you'll see progress in enrollment and retention by the good screening.
So Dr. Nathu, can you talk a little bit about we talk a lot about big data. What does big data in cancer mean? And then how can we use it to take care of patients better?
Great question. Before, when we used to do studies on how many patients had a certain disease, how they presented, what they looked like, we'd take a small sample of the country and the entire discipline of epidemiology was born, and we would sort of draw some statistical conclusions about the US. We're in this incredible era where data is not only available, but can be linked across different institutions, different care settings, different types. Like I can look at the race and ethnicity composition of a population and look at that against mortality and look against the entire journey of that patient. And when you start to do that at scale, you develop this incredible appreciation for just how much disparity affects colorectal cancer. It is an incredible challenge for all of us when we see Black patients having delayed treatment from the point of diagnosis. When we think about this from the journey of predicting which patients are likely to have cancer, that a young Black man is likely to show up in the emergency room with anemia and not get a colonoscopy compared to a white counterpart, we can use that to drive better intervention. Now, beautiful thing is we know where that's happening. This doesn't require precision oncology, precision medicine, just says, let's just look. Let's just look at what's happening today. Can we make decisions? Can we actually say, maybe there's a very simple intervention that says, if somebody comes in with a certain presentation, let's test a low-cost intervention to bring them to the table. And maybe there's a study that's in there. The ability for us to use data to drive that is incredible. Now, it took a global pandemic to get states and the federal government and private institutions to share data, but why don't we treat cancer like that? Why weren't we all sharing the data on who's presenting, how they're presenting, putting them into national registries, putting them into a way that researchers can get access to them, because that's what drives innovation in this country. That's what makes this country incredible. But we have a moral obligation, we have a duty as Americans to do this for our population, and we think data is this incredible unlock, and we're in an age where it can be done. That's what's amazing about it.
So I feel like you're talking a bit about real-world data, right? And so I think there's both excitement and some controversy about how we can use real-world data. And so I'd love to hear a little bit from the panelists about the feelings about using data that isn't as well gathered as on a clinical trial where we have very tight requirements for data that's gathered, but using that to change the way that we treat patients, or as our control arms, as Kathy, you were mentioning. Many clinical trials have to be compared to something, and the FDA has been very reticent to allow controls that are not gathered within the context of a clinical trial. So I'd love for us to spend a little bit of time on that.
I'll say something to start with because I am in the real-world data space. So the FDA put out guidance just at the beginning of February that lays out conditions for using real-world data in studies. It is incredible, and it is going to drive a whole generation of research that can be done with data as control, which is so incredibly important for patients who may not get life-saving therapy. I think the broader question, though, is that there is sampling bias. There's bias in everything we do. There is bias in the data we receive from a provider, from a payer, from a patient panel, and correcting that bias is like literally the first action that any of us can take before we plug it into AI, before we talk about machine learning and large LLMs, and before any of that, we have to address the bias in data.
LMN?
Large language models like ChatGPTs of the world, like the ability to study, large corpuses of information, but it's just this whole idea that when we systematically identify and address bias, then if you're training an AI off of that, you have far more confidence it actually reflects the dynamics of this country, of the folks on the ground that are having the experience of cancer.
Just to respond to that, I actually think that we have a real failure on the part of really cancer research at this point, that we're not utilizing the potential that we have, not only from the real world data perspective, but really just the fact that we have the potential for a learning health system within the cancer context. And one example obviously is that we have, of course, at the NCI, I'm not going to give you the alphabet soup, but we have a division that focuses on treatment, and other that focuses on prevention, but also prevention of side effects, and another that focuses on some of this big data work, epidemiology and things of that nature, and looking at EMRs, electronic medical records and such. We could actually utilize the patients that we're treating in the real world setting, as well as patients that we're treating on clinical trials, to better learn how to manage, control, and deal with adverse events that are occurring because of our cancer treatment. There are many that occur as a result of colorectal cancer treatment. There are many patients that suffer from things like peripheral neuropathy, where they have pain in their the tips of their fingers, tips of their toes because of the treatment. And we've done virtually nothing to alleviate that pain and suffering related to cancer treatment over the course of decades. Now we're in this era at this point with targeted therapy, immunotherapy, and we have some potential actually not only to learn how to deal with these adverse events to help ameliorate the immediate problems associated with treatment, but also to learn how we might be able to better understand resistance to therapy, because normal tissue responds in many ways, unfortunately, similar to cancer-related tissue. And we can use the information both from clinical trials, electronic medical records, and such to better drive innovation in cancer. It's a missed opportunity, and we need to be doing more for these patients.
So I'm just going to echo a little bit and add on what you just mentioned regarding real-world data. I mean, the reality is you can take a lot of our practice patterns as medical oncologists and incorporate it and it helps the patient in reducing their side effects. So, for instance, we know that the FDA insert for capecitabine is not what we would normally give a patient because it causes a lot of toxicity. We know that during the era of COVID, and actually many of us were doing this for many, many years, we were omitting 5-FU bolus and leucovorin because it results in myelosuppression. And so all of a sudden COVID happened, and everyone's like, oh, maybe we should do that. Well, I've been doing it for over 10 years, and so have many of our other colleagues, right? But we had to put that in publication, but that was real world data that helped change what is, how patients are tolerating their therapy. Because being in practice, even though none of us are in practice full time, right? We do clinical research, et cetera. We can give a lot of advice on what would be appropriate for a patient so they could tolerate their treatment better and it can prolong their survival.
And from a real world data perspective, one of the things that we as patients look at is access to palliative care being very, very underutilized. We talked about navigation earlier. Palliative care can connect you to mental health services, to pain management, to sexual health and dysfunction. And all these things are things that we talk about within the community, but so many people confuse palliative with hospice care, and they think, oh my God, you're on palliative, you're on limited clock, and it really isn't. So I think that that's another area where we can identify through the data, this person needs some support services, how can we connect them?
Yeah, I think on that front, one of the things that is a challenge with clinical trials that deal with symptoms is that there's not much financial gain in them. And so they're just not areas where there's a lot of private development. So I would love to hear what do you think stands in the way of doing those trials from a patient perspective? Or do you think that it's purely just that they don't exist and they don't know about it?
I think it's a combination of both. There's a lot of need for what's available out there. When you're looking at trials, most of us think of something that's going to be saving my life. And in this world, it's precision medicine right now. But if it's something else, those trials typically get a little more lost. So finding a patient champion, we were talking about influencers earlier. The patient community, we really talk to each other. And so, I remember there was a drug that my oncologist had recommended to me because I had, Folfox and Folfiri, and it failed me. And he kind of said, well, there's a new drug that just came out, and I had already known about it because I was talking to my patient peers. And I was able to say, nope, not the quality of life I want, what's the next option? And I was able to stand up and do that, but how many people don't do that?
And this is an area where some of the kind of data aggregation methods that you use could be very helpful to see what practice patterns are and what works and doesn't work potentially, yeah?
Absolutely. I think the beautiful thing about the way that we can trace journeys is that we can now get the data out of EHRs and out of payers, like the claims, and from testing companies, where we can actually get genomic information, and we can bring that all together to study these patterns. The problem is not one of interoperability. It's always been one of trust. Everyone feels like they're giving something up when they share data, and they're not sure that they're going to get something in return. And so what we've had to really evolve is a set of mechanisms that get people to share in the name of public health. And then we share that with our advocacy partners. We share that with patient advocacy organizations that are really there to then help the patient navigate through those opportunities. So I feel like the quest is actually to get folks to share for public health, and the government is the best mechanism to start driving that behavior in a system that reimburses private institutions very, very well for the care that they're providing. How do we make sure that that information then gets shared back so we can learn something, we can do something for patients? So we're big champions of that, and I feel like we're at that time when this has to be in the national consciousness, the discussion around how we use data to drive better care, and then how we use data to measure performance so we can set accountability for the work that we're doing.
Kathy, you had mentioned precision medicine, and that is an area where we can match patients based on their biomarker with therapy. But now with technology really being able to create groups of patients that aren't based on just one mutation, and where there isn't already a company or many companies set up that do that work, What do you think the obstacles are right now to being able to translate all of this biological work and knowledge that we're gaining into how we select patients? What do we need to invest in now?
Oh my gosh, that is such a great question. I think the number one thing we need to invest in is we need to still educate patients about the importance of molecular testing. I'm still seeing a lot of my patients that come into my clinic that have not been tested, and that can make a huge difference in their treatment because they are potential actionable mutations. Honestly, really just focusing, I think, from my perspective, always, in order to make greater advances, we need more people to enroll to clinical trials, and we need people to feel more comfortable. Some people are concerned that they have the term mutation does sound scary, but in fact, it's a molecular alteration for the majority of our patients, and in fact, it can help you as a patient in regards to treatment options. I personally believe that we really need to still educate our patients as well as educate our treating physicians out in the community, and also there's multiple companies, as you mentioned. The reports that are provided by the various companies, some are very complicated and very difficult to interpret, and sometimes that treating physician and the patient who's trying to be informed does not understand what it means, and that actually can obviously serve as an obstacle.
So I really loved the question from the earlier moderator about what you would do if you had $1 billion. And I think it's particularly important when we're talking about innovation. So I'm going to increase it because this is government, so we can do more than $1 billion. So, but if we had $5 billion and we were going to invest in something that was going to really innovate how patients are treated or give patients what they need to improve their treatment journey, what do you think that we should be investing in?
Well, speaking from where I sit, we should be democratizing access to the data that will help folks get to treatment faster and better, to highlight the disparities, to address them, to share across public and private institutions, to be open about that, and to do it for patients. And I would devote a big chunk of that to driving that policy change and then ensuring that we hold all private institutions accountable.
You know, I keep going back to earlier panels and the things that we've talked about. Getting into the communities is important. The government can put out PSAs. You know, we looked at smoking campaigns way back and look at the effect that it has had now. So if we normalize colon, rectum, you know, these words should not be scary to say and to talk about, and it shouldn't be something that's shameful or have a stigma to it, right? So if we have these educational pieces with the PSAs, if we get into the communities and we provide the supports throughout the journey with these navigators, I think that you're going to see a tremendous impact and increase in diagnosis more earlier and treating those that are diagnosed later as well.
Okay, so that's $2 billion. I've got 3 left, right? So I think that there are probably several things that I wish we could do. I think that we need to work more on endpoints. I think it was mentioned before, and I've heard as almost an aphorism of science, what cannot be measured cannot be learned from. We need to learn more about circulating tumor DNA, which is one way that we might be able to use a particular endpoint that is more exact than many of the ones that we have right now, potentially for screening, at the screening that we talked about earlier, but also screening for metastasis and evaluating patients for response to therapy. That can make a big difference, especially if we did it in a platform manner to better understand what types of individual mutations or molecular alterations or other problems might actually be able to be detected in individuals so that we can subset them and find treatments that are appropriate for those patients in particular. I think very much that we do not do nearly enough in symptom science. We do not do nearly enough in immune-related adverse events. Immunotherapy hasn't worked quite as well in colorectal cancer, at least microsatellite stable colorectal cancer. But it's important to note that just a few weeks ago, there was an approval for rectal cancer for patients that have MSI high status, a particular type of status that essentially resulted from a very, very small clinical trial out of Memorial Sloan Kettering that showed that patients who received a particular immunotherapy had functional cures, did not need surgery, did not need radiation or chemotherapy for their rectal cancer. And it's really just a testament to what we can do if we find the right treatment for the right patient at the right time. And obviously we need to do that, among other things, but I guess I've used up 2 billion, so I think you've got
So if there's anything left of the 1 billion left or half a billion left, I'll take it. What I would like to see, number one, is improved access overall for individuals, not only in regards to education, but because that would help with screening and awareness, but also, once again, trying to incorporate telehealth, trying to work with our retail pharmacies to learn how we can include them in the process of clinical trial enrollment so we can get these trials completed quicker and faster so we can get more advances. But more importantly to me, for my role, I would love to have greater reimbursement, nothing against the NCI, but I would love to have greater reimbursement for our NCI sponsored studies, because currently we have lots of great thought leaders amongst the cooperative groups, and we need to have more institutions engaged with the NCI, NCTN clinical trials process so we could have these trials completed once again. That's what I would like to see. And then pharma companies would give us more of their more novel therapies. They'd be more vested.
Yeah, and I think the wonderful thing about that solution is that while it's not low-hanging fruit financially, it is low-hanging fruit in terms of it really just is a dollar's investment that could really make a meaningful difference. I'm going to answer my own question as well, that I really feel like a passion for trying to get trials into patients' communities. I think we need to really work with community oncology. People should not have to travel to academic centers to have access. That makes a huge difference when it comes to rural communities, when it comes to communities of color, but also all communities. People shouldn't have to travel so far to be involved in clinical trials. And so a national dialogue on that comes both from the NCI and brings in private partnerships. There's some private companies that are working really excitingly in this space, but I really think people should be able to be taken care of in their homes and still be able to get top-notch research. So I think that we are out of time. This has been a fantastic panel. Thank you so much for the invitation.